Good morning, everyone, and welcome to our final day with the School-Based Healthcare Conference. Welcome to this morning's School-Based Health Center Resources, Training, and Technical Assistance Hour. This morning's session is called Tackle National Teen Mental Health Crisis with Effective Screening and Referral Program. I'd like to introduce our two speakers today. I'm Andrea Shore with the School-Based Health Alliance, and it's my pleasure to introduce both speakers this morning. Our first speaker will be Evan Elkin. Evan Elkin is Executive Director of Reclaiming Futures, a national public health organization focused on improving health equity and justice in youth-serving systems, including schools, child welfare, and juvenile justice systems. He's a nationally respected innovator and leader in the field of juvenile justice reform, adolescent and family mental health, substance use treatment, and youth development. He was originally trained as a psychologist at New York University and researcher at the New York Psychiatric Institute and Columbia University's Department of Child Psychiatry. His work for the past 2 decades has been at the intersection of public health and social justice, focusing on the nation's most vulnerable populations. He was the director of the Department of Planning and Innovation at the Vera Institute of Justice in New York City, where he was on the senior management team. And he operated a fiscal sponsorship program for emerging nonprofits and advised them on board development, strategic planning, and fundraising. He's also the author of a screening and brief intervention model, SBIRT, that is widely used in schools across the country, and is the model developer for the acclaimed Adolescent Portable Therapy Treatment Model, which was a finalist for the Harvard Innovations in Government Award. He's worked extensively with tribal and non-tribal youth justice settings, schools, and child welfare settings to help advance public health and social justice through innovation. Our second speaker will be Dr. Sandy Whitehouse. Dr. Sandy Whitehouse is the Chief Medical Officer of Ticket Health, which is a company founded to enhance the communication between patients, students, and providers. And the research behind Ticket Health was initiated by Dr. Whitehouse, who's an adolescent physician. In her time as medical director of emergency services at BC Children's Hospital, she routinely struggled to obtain accurate and complete information from her young patients. Testing through various innovative methods, Dr. Whitehouse was able to obtain a more accurate information from her patients by putting a validated questionnaire onto a digital platform, using images and icons appropriate to her patients that led to having more engaging conversations, identifying critical issues, and rendering appropriate treatment. After today's two speakers, I'll come back on and moderate some questions and answer time from the chat box. So with that, I'm going to pass it on to Evan Elkin to begin.
Thank you, Andrea. It's a pleasure to be here. Been a colleague with the School-Based Health Alliance for some years now. We were co-grantees under a very important initiative funded by the Conrad and Hilton Foundation. And some of what you'll see us talking about today was created with seed funding from the Hilton Foundation. And I want to just thank Andrea and Katie Stinchfield, who have been great colleagues at the School-Based Health Alliance. So it's great to have you all here. As Andrea mentioned, and from the title of our talk, we're going to talk about a universal screening and brief intervention model designed for both middle and high schools. And Andrea mentioned, I'm here with my great colleague, Sandy Penn Whitehouse, and I'll talk a little bit about our partnership and why we have been so attracted to the technology that Sandy's organization, Ticket Health, has created. As many of you know, I think you're familiar with the concept of SBIRT and screening and brief intervention, and there is not necessarily a particular screening tool implied by the S in SBIRT, but we have really settled on a tool created by Ticket Health called Check Yourself, and in large part because of the incredible collaborative spirit of that organization and a dynamic that evolved over the course of this multi-year project to allow not just us, but other stakeholders in the community of teachers, staff, counselors, kids, to give direct feedback and input into this tool. And we've arrived at a tool that we really like, and you'll hear a little bit about it today. So just a word about reclaiming futures. Andrea mentioned, a few words about it, but I just want to say that, we've been working in youth serving systems, particularly in initially juvenile justice settings for 22 years now. And our work is across the country. We have projects, current and past in 22 states. And we have a lot of active work, particularly now in Native communities, doing work similar to, in theme to what we're going to talk about today, this idea of how do you define problems in a public health setting? Who gets to define what tools do you use to define them? And with Native communities, as you might imagine, it's the cultural aspect of, how do you define when a young person has gone off track, and how does the culture define the pathway back into the community and to wellness and to better citizenry or mental health. It is probably clear to all of you that these concepts are largely cultural, and the Western definitions don't always apply. So we're very excited about our work in Native communities, and we've created 2 SBIRT models in 2 different tribal communities, one in Colorado with the Southern Ute and one in California with the Yurok Indians, and happy to talk about those another time. So our general mission is to integrate public health models and build public health oriented models in systems where both public health and justice hang in the balance. And I think that the really obvious place that takes place is in justice systems, which, in youth justice, many of you probably know, sometimes is a treatment setting of last resort. Justice systems and juvenile courts are often in a particular community the biggest referrer in that community to substance use treatment and mental health. And so how do you help them perform that function while at the same time perhaps re-empowering the community to play that role and not to overfunction in that regard? Because the system was not built for that, but has been leaned on and burdened with public health demands over the years, just because of who enters those systems and from what communities. A lot of communities devoid of resources end up having to get treatment in juvenile justice. We have focused much of our attention in the last 5 years on schools, and we have moved upstream of the justice system for reasons which will be obvious to some of you, that prevention and early identification of difficulties is one way to interrupt what some people call the school to prison pipeline, and just to get kids identified and get them help sooner than when they end up in these other kinds of systems. So that's us. Why are we here at this conference, and what have we been doing? And a lot of people talk about, during the pandemic and during the time of COVID, that we are now, or we have suddenly noticed that there's an urgent public health crisis among youth, with increases in anxiety and spikes in suicide, et cetera. Most experts and people who have been around will tell you that it was not the pandemic that started the spike in the acute issues among teens and adolescents, that this was percolating, and that maybe the better frame is to say that the pandemic threw a little gas on the fire. But it's clear right now that our adolescents, having been isolated from school, under stress with lots of loss, all of the various root cause reasons we've been talking a lot about lately, are experiencing more mental health issues now than ever before. And youth serving systems, including schools, are really stressed and stretched like never before. We know this because we partner with them and approach them all the time. It's we hear a lot about how they just don't have the bandwidth. They're putting out fires constantly. So the reason we're here is that we have a program that we're really proud of, and we're going to talk about it, to help schools get out ahead and manage the mental health issues in a school-wide framework within their buildings. You hear a lot about interpersonal violence here in Portland. This is a crisis. There's more fighting and violence and suspensions. We had a school recently, one of our biggest high schools here in Portland, Oregon, closed shortly after a lot of schools were reopened. They closed again, not because of the pandemic, but because they were not able to control the amount of violence in the hallways. Attendance is historically low across the country, and this is a sometimes triggers a funding crisis for schools who require attendance to justify their budget in the next year. And this is something that I want to talk about. We won't talk about a ton here, but the staff, the adults in the building, and the amount of burnout and emotional distress and turnover that's happening. My son is in elementary school right now, and the first through fifth grade teachers, all 5 teachers resigned this year in that school. And so it really begs the question, what's going on, and how do we support the adults in the building too? And that's critical to supporting the young people. We'll touch upon it, a tiny bit, but I just want to name it for now. So what is a school's role in youth mental health, and what are the expectations? And I think the question itself is really important, because schools feel under a lot of pressure right now. A lot of the new funding, and there doesn't seem to be a dearth of funding, but I think direction and frameworks to follow and models are really one of the critical missing pieces to this, is that schools are suddenly being looked at as the place that has to fix this problem. And I know that that puts schools under a lot of stress and a lot of distress. So what is the answer? I mean, I hope we're coming with a solution to this technical assistance panel here today, and that folks who are observing this panel today, who are from school settings and looking for strategies, will talk to us. But there are other approaches that you see, and one of them is the hiring of clinicians in schools. And this is somewhat of a rhetorical question, maybe a leading question, but is increasing the number of clinicians in a school a feasible response, and is it a long-term solution? Obviously, I'm a public health person, and the public health lens that looks really at health promotion and prevention, for me, is the place to put your investment. But you see a lot of school districts around the country looking for funding to bring clinicians into the school, which is not wrong. But it's kind of like that analogy of, do you pull drowning people downriver out of the river, or do you look upriver for why they're falling in the river and drowning to begin with? And obviously, I have a bias, and perhaps the answer is a combination of the two. But is it also about opening your doors as a school more to the community, and engaging community organizations, not just treatment organizations, but organizations that represent the youth development and the family support and the culture and ethnicity of the kids in the building, to help them to feel more connected to their school. And some of you may have some involvement in the Communities in School model, which is sort of what I'm referencing here. But we have a belief that doing that is a public health maneuver as well. Some of the middle schools where we work in, and the high schools, there's one in particular where 80 languages are spoken, and it's largely an African-American community. And that school, with our collaboration, has worked really hard to bring in community-based organizations from those cultures to take part in the public health practices, to get involved in the screening and the brief intervention. And also really, the assumption that I think a lot of people make is that schools are doing nothing. And that is not true at all. Schools for years have been engaging in social and emotional learning, model building, been looking at reforming school discipline practices and building more of a relationship restorative approach to discipline. And a lot of those strategies are about wellness and school climate, are really part and parcel to school-based mental health. So this is just a plug for schools, that it's, a lot of people may look at this crisis and think like, what the heck have schools been doing? But they have been doing a lot. So the model we've brought to talk to you about today, we've implemented in more than 50 middle schools and high schools across the country. The majority of those schools are in King County, Washington, where we've had a large scale countywide implementation. And some of the data I'll present today comes from that implementation, but we're also, in the in the South, in Louisiana, and the state of Vermont, and in Ohio. So more than 30,000 youth have been screened to date using this model that we're going to talk about today. We have been building materials. Our focus really is about dissemination and sustainability, and figuring out over time where the mines are in the minefield to help folks implement this without having to reinvent the wheel. And so we have a really solid practitioner guide. We have an implementation playbook, which I think the link is going to be placed in your chat, your participant chat. and can be sent if you want to put your name and introduce yourself in your email. I can send you the PDF of this, but our implementation playbook is in the public domain, and it's a step-by-step guide to how to implement this universal mental health screening and response program that we've developed. We've also in development and almost ready for prime time is a guide for how to use the data that's generated from a screening program like this. I wouldn't quite say it's data for dummies, because a lot of schools really know how to use their data. Most states have a statewide mental health survey that policymakers in school districts look at to then shape policy. When you see spikes in anxiety or relationship violence, or the things that get reported in those anonymous surveys, very commonly fuel changes in practice, introduction of curricula, et cetera. And so that's something that is available through the data function of the screening tool that we have, and we encourage counselors and policymakers in the schools where we are to look at what's emerging from the practice and make, sort of develop curricula, tweak practices, just to be aware of what the population is experiencing, although largely our model is about individual kids and meeting individual needs. So we have a training and implementation support program and a faculty that delivers this. We've also developed and piloted a staff wellness support tool, back to my comments about burnout, is so that we have a way to offer school administrators, the cafeteria people, the teachers, a way to self-reflect and look at their own wellness and meet their needs. And that's something I'm not going to talk about in specific today, but if you're interested, you'll have our contact information. So our approach to school-based SBIRT, screening, brief intervention, and referral to treatment. I can't see you all. This is the kind of moment where I would say, show of hands, who knows what SBIRT is? And I'm going to talk about it in more detail. But our model is designed to align with what has become increasingly common in school settings, the multi-tiered systems of support, which looks at school-wide, sort of usually it's represented as a pyramid, where at the bottom of the pyramid are the school-wide practices, the climate interventions, and all the way at the top is usually, a smaller section, usually represented in red, as you'll see on my pyramid I'm about to show you, but has to do with the emergent responsive practices that a school develops. We, as I said just a moment ago, we consider this a data-driven strategy because so much data becomes available through this process, and it is confidential and anonymous, and we can talk a little bit about that, especially if you have questions. We've spent a lot of time thinking and responding to questions about anonymity and confidentiality because of what we're asking young people and the sensitivity of that information. Our model really is about relationship building. It's not a surveillance and case finding tool to find out, who's feeling what and who needs help. It does that, but it really does that through relationship building and a collaborative strategy with young people. It deliberately looks to align with what else the school is doing. As I mentioned, schools do a lot. Other reforms that are taking place around helping kids to problem solve, trust each other, communicate more. So we try to align our approaches with what's already happening. We have the two versions. We have a high school and middle school version, which were developed by experts and vetted by kids and counselors. Right now we have translations in Spanish and Vietnamese, and plans for other translations down the road. So this is SBIRT, less than 101. Really, what is it? In some ways, it's it's the shiny object that for the last 10 years has been really trendy. It's got an acronym, and it's got everything you need to be trendy, but it's been around forever. Public health is really about screening and then doing something about it. So the blood pressure cuff that gets slapped onto your arm anytime you enter your medical care setting is sort of the original universal screening tool. But that information from the blood pressure cuff or any screening tool is insufficient to make a plan. If I walk into my doctor and have high blood pressure, questions ensue, like, how long has this been going on? Do you have a family history of this? What's your lifestyle all about? What's your diet? So the brief intervention is the contextual clarity that you need to help interact with a client or patient to figure out what to do next, whether to make a referral, to support the likelihood of a referral by motivating. Doctors sometimes like to scare you by telling you, oh my God, your blood pressure is off the charts. This is what you have to do next. In our model, it's intended to be much more of a collaboration. Since, with mental health and behavioral health symptoms, context is critical. So our school-based screening and brief intervention model, to drill down a little bit and get more specific, we use a tool called Check Yourself, which is developed by Ticket Health, and you're going to hear a lot about it from Sandy and a little bit more from me. And the brief intervention is a conversation that happens after screening with a school. We call it interventionist, but it can be someone from various professional walks of life within the building. We have an assistant principal doing it. We have school nurses. We have school counselors. Sometimes it's outside community-based organizations come in as contractors to do the brief intervention. And the core of the conversation is based in motivational interviewing, which is really one of the best kind of counseling innovations in the last couple of decades in terms of adolescents. I mean, we used to not have a field of adolescent treatment, really. We just treated them like miniature adults and used our adult models. But motivational interviewing, where you really try to derive what it is that drives a person, or what they might, what reasons they might have to make changes, or what their goals are, that approach seems to be uniquely aligned with the adolescent psyche and has been a very effective way to move kids from point A to point B to a referral, or at least to help them define what they might do next when they're ready. And then the R, obviously, in SBIRT is the referral. And we think of the referral not just as a clinical referral, as you'll see in a slide later. A referral can be, this to reconnect with a social group, tutoring help. It really is about any support needs that an adolescent has, and which are really all the building blocks of wellness for adolescents. It's not just symptoms or not symptoms. Here's that image I mentioned of the multi-tiered framework. We add a fourth foundational piece to this, which is all the things, if you're implementing a school-wide screening mental health checkup kind of program like this, the groundwork you have to lay focuses a lot on transparency and communication with caregivers, to onboard families as seeing that this is part of the school's mission, and to have a chance to push back. And so it's that sharing and building of collaborations in the community that really precedes all of this. And then traditionally, the three-tier framework has to do with the bottom green as a school-wide health promotion and prevention type activities. Tier 2 is typically the kinds of referrals and not emergency level stuff that happens in schools. And then Tier 3 being things like suicidal ideation, risk of self-harm, those kinds of things that need immediate action. And we've organized our model around this framework, and the tool itself, the screening tool, also follows this model as well. So I mentioned our implementation playbook. This is kind of a busy slide, so apologies. It sort of violates the cardinal rule of PowerPoint here, putting too many words. But this is just the organization of the playbook. That the project seeks to bring about both systems level and student level change to help align the practice along the tiers, to build partnerships. Those are the systemic level changes. And really the goals are to address unmet needs, engage students, help them feel more connected. And the plays themselves follow a stepwise process that we learned by trial and error, by implementing this for the last 5 years in King County and across the country, what you need to do first, second, third, and all the way up to the 9th play, which is how you use the data to continuously improve your strategies, to feed back the data on yourself and improve your practices. And so the first play, I won't go into all of them, is really about a detailed and in-depth conversation of how does this fit in with what we're already doing? Where are the redundancies? How could this enhance here? And really do this by school-wide committee and not just try to plug something into a square peg into a round hole. So this is a sample screen. I'm going to jump into the acronym itself. Screening, we use the Check Yourself tool, as I mentioned. A lot of other SBIRT programs use different screening tools, much briefer ones. We use a fairly in-depth one, but a fairly efficient and short time allotment tool. As you'll see, I have a slide about that. But it really, an opening screen that, you know, helps to orient the kid and gives them the choice to accept or decline. All of our programs so far are completely voluntary. Anyone can opt out at any time, and parents can opt out of having their kids involved. The Check Yourself tool covers the whole kid. You can see there are three major categories. The stress and coping and health and safety are where the symptom stuff lies, where the stuff that you may be most interested in, how to assess and screen for those things. But it has a lot of strength-based stuff about coping, connections to adults in school. And that variable, how well connected kids feel to the school, has been a really critical one for us, and one of our kind of encouraging and surprise findings in terms of the outcomes of doing SBIRT. The tool itself is comprised of subscales, the PHQ and the GAD, which are validated. People always ask, you know, is this a validated tool? It contains two of the strongest validated screening tools, but also is this kind of whole person interactive tool that Sandy will talk about. It's first used in pediatric settings, and we've adapted it for middle and high school settings over the course of you know, a lengthy process with an expert committee with clinicians and school counselors. And then once it was, you know, partially baked, vetted with students and practitioners, it's really been, and this is partly why we love our collaboration with Ticket Help, is that the tool has been undergoing this constant evolution in a very systematic way over time. Things that are not sensitive to the kinds of things we want to measure are removed. The things that need to become more sensitive to, you know, finding kids who need our support are enhanced. It's been a really fascinating process over time. Again, we've used it with 30,000 kids so far. And then for me, you know, I've mentioned this a few times so you can tell how into it I am, is that it produces this real-time report about the kid himself that you then use as your conversation starter for your SBIRT, your brief intervention, but it also aggregates data so that you can begin to look at the sort of the global population and the environment that you're operating in. So this is a slide about the nature of the tool itself, that it's about responding, reporting, and data-driven decision-making. And I've covered that. I think Sandy will talk about this, but it has a way of sorting and prioritizing the symptoms that a kid presents, so that the clinician has some efficiency of seeing, have their eye drawn to the things that might be the hottest things to talk about when you do sit down with a young person. The brief intervention, which can be 15 minutes. It could be a series of 15-minute interactions. We've broken it down into these elements, and if you have time, you can get through all of the elements. But essentially, it's about appreciating the whole kid and sending the message to that kid that you're interested, not just in the symptoms as like kind of a gotcha, what are we going to do about this? You said this, what do you know, but to really appreciate the kid, start with, you know, understanding, showing them that you want to understand who they are in their context. And as we talk about cultural humility a lot, and that's also about context. Our assumptions about, you know, how kids are and how they should be and what they should do when there's a problem is not always informed by the cultures that they come from. And as I mentioned, one of our middle schools has 80 languages spoken, and so we tread very humbly into that territory with kids who are new Americans. We talk about it as being collaborative and respectful. This is a negotiation between the kid and the practitioner, with the kid really in the lead and putting symptoms into context. So we don't just use clinical context in our assumptions, but having the kid put them into context so we really get to know them. We try to involve parents. I have to say it's been one of the bigger challenges is to integrate parents into the brief intervention. We have curricula for that within the practitioner guide for how practitioners can integrate the parent into the conversation and get their support and empathy and mobilize them to help. But it's tricky in school settings. You guys are all school people, so you know the barriers. But we've been building on that over time. Takes about 30 minutes to do a full classroom of the screening, including setting it up and doing the instruction script of what kids need to do. They tend to have an iPad or a tablet in front of them. The sorting and triaging. Some people don't like the word triaging because it sounds too medical, but it really is about, you know, say you screen 30 kids in a classroom. Who are the top 3 kids that you want to talk to right away? who doesn't really seem to have any symptoms, who could probably wait a few days. So that's the sorting process. That meeting takes about an hour. And so this is just a snapshot of how we've been doing. You can see this data does not include year 4, and we're up to about 30,000 kids screened. Year 3, as you might imagine, is the COVID year for us. We transitioned to remote screening using Zoom and some pretty creative and I think very responsible practices of using a lot of breakout rooms and not exposing any kids, inviting everyone to a breakout room so no one feels like they were singled out if they needed a brief intervention. Advanced communication with parents so that there is a parent in the home when the screening is being done on Zoom. And in King County, they screened hundreds of kids using Zoom, and it was pretty impressive. Just a sense of what gets endorsed on a screening tool like this, and it probably, I don't know, maybe it surprises you, but it aligns mostly with what you would think you would see based on statewide surveys. About 1 in 10 kids will report self-harm, and so those kids in the red zone, the tier 1, are in the minority, and the bulk of what gets reported are these sort of medium-level tier 2 anxiety, bullying, depressive symptoms, but everyone gets responded to. So this is just the percentages in year 1 and 2 about who received a brief intervention, and the percentages are really high. Kids who are in tier 3, meaning the emergent kids and the suicidal kids, 90% of them get seen within a day. Actually, 82% get seen within a day, 97% get seen. And there's some missing data here. Some of them, if it's a kid that's already known to the system, or a kid who clarifies that their response really didn't mean suicidality, early in the process, don't necessarily get referred. The goal is 100% for all of these, but this was our data in years 1 and 2. One of the big findings for us is, and for the stakeholders in the school buildings, some of whom were doubters about the utility of this model at all, is that about 22% of all kids screened identify a new need that nobody knew about. And about half of those kids identified 2 or more actionable needs that, amenable to a referral. We introduced an element in the practitioner side of the screening tool for the practitioner to indicate when they learned of something new that they didn't know about. So these are basically what this does is it shows that we surface the internalizers, the kids who are not showing the level of distress that they're in. And those new needs, nearly 60% of them are in the red zone of kids who need an emergent care. And so this is a big selling point for us, is that even though you're a fantastic counselor and your door is open all the time for kids to walk in, there are quite a few kids that you do not know are suffering and in need of services. And this program really helps with that. Just a little breakdown of the kinds of referral types that were made in our first couple of years. A lot of in-house referrals to counselors, which is good. The counselors feel like they're getting the right kids, and a fair amount of non-clinical referrals and referrals to outside community partners. We ask about this protective factor, which you'll see in a second why I'm showing this, is that we ask about connections to adults. Is there an adult that cares about you? Is there one that gives you positive feedback? Is there someone that listens to you, et cetera, believes you will succeed? And these are the breakdowns of kids at baseline when you just sort of see them for the first time pre-SBIRT. But this was one of the really exciting and positive findings in our work, is that in almost every indicator of a connection to the school and to adults, the experience of SBIRT and going through the process, largely because the process is about relationship building and connectivity, kids feel more connected and more cared about and more listened to. And so this is something that we're really excited about. Just a quick recap. You're finding a lot of the internalizers. Kids feel more connected after the process. A rolling and universal screening, like when we say universal screening, which is really what we insist on, we don't mean screen 2,000 kids at the same time, but to screen a classroom at a time so you don't overwhelm your system. And indicated screening, which some people call targeted screening, when we allowed schools in year 1 to kind of wade into the process and only screened kids that they thought they were worried about. It showed some dramatic inequities that Black and brown kids were more likely to get screened, those with difficulties, and Asian and white kids were underscreened, those that ultimately ended up having difficulties. So universal screening is really an equity intervention, and it's really the way to go. So I am talking a little fast because I think I don't want to step on Sandy's time. It's very exciting for us to work together on this panel, and I'm going to kick it over to Sandy. We'll stick around for questions at the end if we haven't eaten up all the time.
Thank you, Evan. And hi, everyone. And so yes, I'm Sandy, and I hope you can manage with my accent. I'm originally from Australia, but very happily settled in North America. As was mentioned, I'm a pediatrician by training, and so what I found in my work was that we were really missing those kids at high risk, and I always kept looking from our patients or students' perspective as how we can meet them where they're at, how we can look at from their perspective. And I wanted to create a safe space for kids to share personal and sensitive information. So that's a decade. We've been working on that for a decade. And then over the last 2 years, and particularly, I mean, we've been working with Evernote for a long time, but over the last 2 years, I've become increasingly aware and increasingly concerned about you as providers and administrators working in the school-based setting, and with the overwhelming changes that have occurred, and the challenges in doing the right thing to help young people and to create to do sort of effective interventions for the right student at the right time. So we have a technology, a technology foundation, and what we've been working on in these last few years is how to make it easier for you to manage the data, how it's easier for Evan and his team to work with us, and so that you can feel confident that you're both avoiding risk and reporting accurately and managing an overwhelming workload. And we really have enjoyed the collaboration with Evan and Reclaiming Futures, and also with our work with Seattle Children's Hospital in creating this Check Yourself tool, and then to look at all these workflow processes. So I'm going to speak a little more about the technology and how it works, and why it's a bit different. So one of these challenges, as I said, were the communication barriers between young people or even families, and that's one of the foundations of health equity, is this people slipping through the cracks. And it's for a whole lot of reasons. One might be language, but also low literacy levels can be a real issue. And so where possible, we've been able to decrease the literacy level in our tools to a grade 4, and I think that that's been very, very helpful. Also, people have different abilities, so that's really looking at about accessibility to and sort of like minor motor disabilities or things like that. And so in all our tools, we've used large font, colors, and big buttons to help with that. One of the real issues is how to address stigmatizing information, and how to create that sense of safety around sharing or disclosing that information. And that relates very much to both privacy and security, but also how questions are asked, and what is done with the data. So in the Check Yourself tool, for example, there is feedback and acknowledgement around the respondents, or how the young people respond to the questions. And so our platform is really for the students' perspective, is really about their entire journey, not just the screens that look a little bit different. We have done quite a bit of work also with tribal, Indigenous or First Nations groups, and adapting our tools and platform to that. And we've really enjoyed that work. And I think fundamentally what we want to do is decrease mistrust or increase trust. And we'll talk a little bit about that as well. So the way that we've worked over the last number of years is to incorporate this concept of digital empathy design. And what we are really interested in is transforming those transactional relationships into trusting relationships and doing it at scale. So if one thinks about sort of traditional screeners, they really are fairly transactional. We want this information from you, and can you please provide it? How can we turn that around into more of a collaborative approach? And so these are the 4 pillars here in the circle that we have created our foundational sort of design around: the engagement, trust, encouragement to be a partner, or in healthcare, it's a partner in care, but in a school-based setting, it's about being more involved. And the results that Evan showed was greater community involvement after being involved in the SBIRT program. And then this empowerment, so the platform and the tools give feedback. So the Check Yourself tool we created with Seattle Children's Hospital, it's evidence-based, and then embedded in it are the PHQ-2 and the GAD-2, as Evan mentioned, so validated tools. And it's been used now extensively, as Evan said, in 22 states. And it's strengths-based, so that's a foundational piece with a flagging system that has green, orange, and red flags, so a tiered approach. It's culturally sensitive, and so it can create can be adapted for different cultures, and also can create a personalized journey, and it's trauma informed. So we have included some of the ACEs, the tool has included some of the ACEs questions, again, in a very sensitive way. And the design occurred over a number of years, and it was co-created with researchers and students and human factor design students at the University of Washington, as well as content experts from a wide variety of communities and settings, and then our team, who are very interested in sort of transforming that content into good technological design. And so we've, just to sort of say some of our success, well, in Indigenous clinics, we have worked, this is one actually that's in Australia, which is my home country. And we've been very proud. We've been working with them for a number of years in a youth clinic where they felt very comfortable in using our platform, again, adapted for that community. In hospitalized patients with inflammatory bowel disease, we used a tool that had over 100 questions, and we had a 99% completion rate and some recommendations for actually asking more. So the young people were very happy that they were engaged in this. And in this, with Seattle Children's Research Institute and the work with King County, there was this increase in risk identification compared to what they were using previously. It may have been the GAINS SS, but I'm not privy to a lot of that detail. So again, in a healthcare setting, this was a comparison study of a semi-structured interview and then using the ticket platform. And I think what was really interesting was that there was more data that was captured, plus more accurate data. And in this group that were looking at emotions or mental health, not only was there sort of 89% more information, but there wasn't an increased documentation of depression, but they were able, in this group of 139 young people, to pick up 4 who were had active suicidal ideation using the ticket platform. So very useful and also very efficient in sort of time-wise. So sort of what does it look like? Well, it is about the whole journey and the whole experience. But if we do take one of the screens, we're very big on strengths-based visual engagement. I talked about some of these things before. But for example, the questions, wherever possible, are very short. they're strengths-based. They're used in the first person. We use graphics and color wherever possible. We have clear signaling, so big buttons, and the images are configurable for different cultures. The Check Yourself tool actually starts with my top 2 goals for the coming year are, and there's a number of options. I think it's a really nice way to sort of start what is an assessment screener or a screener with something that feels much more like a conversation. And then we use this whole person supportive approach. So after the strengths-based questions, there can be feedback and education, and then the potential for personalized resources via SMS or email. When we've used this for parent settings, and we did some great work, it's not specifically around what we were talking about today, but with Evan on a tool for COVID with Here to Help, these resources actually offloaded a lot of work for the clinical staff, and so that families were able to get help without actually having to have a specific intervention. And so the platform is very configurable to different settings. Check Yourself is one of the tools that we've used most widely. So basically, we can start off with screening and supporting the young person, and then there's a whole multi-purpose dashboard that can look at unique student reports, and then as well as that can look at aggregated data. And the types of things that the dashboard can allow for is triaging, and I'll show you a little bit more about that further on, but also to notify and alert if there is a crisis response. It can track progress of the student over a period of time to see how they're doing. We have a whole separate tool that is a partner to this, which is being used with Evan's team in some settings. It would be called a provider management tool to make sure that the workflow is completed, up to date, and is easy to do, and it's a place to that matches with the responses taken from the screening to just make sure that the progress is taken care of, and that the care and workflow is done. There is a whole system of analysis and reporting for management and for obtaining grafts. And there we also integrate into various LMS and medical record systems so that the data can go straight into the electronic medical record. It can be used on our dashboard as well as part of the what would be called patient's record. So here is an example of just a pop out of the dashboard with the flagging system that says for this person they had this many red flags, this many yellow flags, but the strengths-based is also noted as well. So that's a great very important for getting good outcomes and for relating to young people. You know, as we mentioned, or Evan mentioned, were able to improve the detection of risk factors that were not previously known in the King County evaluation. And one of the other areas not shown on this slide that is sort of available is for when there is a flag like this, then we can also help support staff with recommended paths of action. So not only do you get the data, but also, and you can individualize that for your institution. So if you would like to set some standards around how you want care to be provided, that can be incorporated into the platform. So I'll stop there and be very happy to, both Evan and I are very happy to take any questions, and excited to hear from you and your thoughts.
Wonderful. Thank you both so much. And welcoming everyone back to the screen. Great, there's Evan too. Please take a moment if you have any questions to go ahead and add to the chat box. The first question I see here, I believe, is for you, Dr. Penn Whitehouse. It says, does Ticket Health have other screeners available besides Check Yourself?
Yes, it does. So it's a technology platform that's, excuse me, extremely versatile. We have with Evan created, as I said, that tool here to help. We've created a guided tool for parents for elementary school. We also have a number of other validated screeners, including RAPS and including the GAD, like GAD7, PHQ9, ACEs, etc.
Wonderful. Thank you. I see a lot of people who put their name and email addresses in the chat, so that's wonderful. So we will get that to our speakers so that we can get follow-up information out to you. Let's see. I don't see anything else coming in yet. Maybe another minute. And we did share the toolkit you mentioned, Evan, in the chat.
Great.
Oh, yes, lots more names coming in. I guess everyone wants a lot of follow-up information, which is wonderful. Okay.
Great. And I'll say one of the questions people maybe hesitate to ask or that we don't mention is our mission is to disseminate this. And obviously there are costs for our time to get out there, but we try to make this extremely inexpensive so that schools who want to do this can do it and can afford to do it. It's really just we're a nonprofit, and it's just our cost to send a faculty out to do the training and a little bit of support over time.
Wonderful. Yes, that is always one of the questions. So I appreciate you capturing. Oh, I see more and more names, and this is great. Wonderful. Okay, we've got a lot of people today.
Wonderful. And I would like to say that, you know, the experience that we've had working with Evan, and then also in Washington State, has been over a number of years, has really created a lot of modifications and adaptations from where we started. So we've learned a lot. A lot of that is put in great detail into the playbook. But we have continuously looked for feedback from both from the youth and from the staff. And I think that Check Yourself as a tool has evolved over time, and to be a really positive influence on the whole school.
Wonderful. Yeah, and actually a few more questions did just come in here to say some of that. The first question is implementation typically school-driven versus the school-based health center medical sponsor-driven? Who tends to?
It can be either. There needs to be a lead. And I think an early part of the process is to figure out how the practice is integrated within the school. The great advantage of a school-based health center is that they have in-house clinicians, and they already have done a lot of the legwork to establish a trusted presence and relationships within the building. So we've seen it implemented, you know, for every 50 schools we're in, it's 50 different ways. And we talk about that in the playbook, and we can talk about that with interested schools, is how much do you integrate community partners? A lot of counselors are worried that this is going to add something to their role. We have found, like, a lot of counselors feel like this increases their job clarity and their effectiveness. And so it really is about looking at what's there and integrating it. And in cases where it's a school-based health center leading it, that's awesome.
Great. Thank you, Evan. Another question came in. How do you push the tool to the devices a student may currently have?
So we have lots of ways that the tools can get to the students. As Evan talked about it being in class, so so we can take the class list and then send it to a link. So it's an individualized link to each student. Everything is privacy and security is really important, and we are for the audience, I don't know how worthwhile, but we're HIPAA compliant and SOC 2 compliant. So those two things speak to the privacy and security. In some areas, we've used things called dark IDs so that they are not the actual, there is no traceable identifier. If we're talking about personal devices like phones or computers, again, we can send those individual links to those devices very securely.
And typically the link is time limited. So it's not something a kid could then at 3 in the morning open it up and give a different set of answers. It really is time limited to that class period. There's a lot of flexibility. And obviously the goal of this isn't just an anonymous survey. So the ability to identify the kid, but to expunge their identifiable information immediately is something that's built into the process.
That's wonderful.
And if there is an integration with an electronic medical record, if it happened to be through a health centre, then they can go out through the electronic health record.
Great. Another question that came in: can you recap how referrals are made and tracked as a result of the system?
Well, as Sandy mentioned, over time we've added to the process, and it's now become standard practice for there to be a practitioner survey element, so that we know in real time when a referral is made. And obviously you'd like to have all the information that you can, like did they show up for the referral, how many sessions did they have? So we have a fair amount of information within reason without overwhelming counselors in school with more record keeping, that they do keep some pretty fundamental and important information about where a referral is made, if they have information about whether the referral took, and any follow-ups. Certainly numbers of sessions of SBIRT, the brief intervention, we need to know the dosage. That's something that we track, and whether a parent was involved, who was present. So, and that's customizable. I don't want to speak for Sandy, but that's the kind of thing that if a school has the bandwidth for this and a desire to know more about the referral part of the equation, that can be built out.
Yeah, and the identification of who's going to get, who needs a referral is also customizable. So, so I think, Evan, we talked, and I showed that flagging system, and the flagging system then generates a risk list or a risk prioritization, and then at that meeting, that risk prioritization is reviewed to work out who should get referred. So I think it really takes care of the kids who are underneath the water in the top of an iceberg. You know, often you're just dealing with the top of the iceberg that you can see. So it's dealing with that group as well. But we've also had feedback that it gives a much more, as Evan said, more clarity and not just an increase in workload to the staff.
And that's been something that has kind of been interesting on the ground, is that certain things you might assume are a red flag turn out to, you know, from a population standpoint, not to be productive conversations to have with every single kid. And so what constitutes a red flag is something that's adaptable by the community, and the practitioners can make decisions. There may be something that's trending in a particular school that counselors know to be associated with other risk factors that they would like to have red flagged, like vaping or something like that, that they have seen a correlation between that and other kinds of behaviors. Ticket can red flag that for a particular school so that those kids are seen and not missed, because that's typically not a red flag.
Wonderful. Thank you so much. That's perfect timing, and you hit on all of the questions that came in. So I appreciate greatly your time. We will share everyone's name and contact information with Dr. Penn Whitehouse and Evan Elkin for follow-up from the chat box. So thank you all. And I invite everyone who's on today to join us in a few minutes at noon Eastern Standard Time for our first plenary session of the day. Thank you all.
Thanks, Andrea. And thanks everyone for attending.
Thank you very much. It was a pleasure. Thank you. Bye.